Good afternoon. Everybody had their lunch and you're ready to roll on some new guidelines. And to me, the guidelines are one of the best things that SCCM does because they give us some direction and when things are difficult. And as our speaker this morning alluded to, the world is getting warmer. We're having more heat waves. They're taking longer. They're more intense, and the seasons are extending. And we're seeing, because of that, we are seeing more injuries. The incidence of heat-related death is increasing. And in the ICU, we in particular see this, and mortality is increased by 3% for every degree increase in the daily mean temperature and the duration of exposure of our patients to the outside. So this isolated climate change is having a real impact on our patients and their mortality. So what is heat stroke? It is one of the leading causes of heat-related death. It's the most severe form of heat-related illness, defined as a temperature of greater than 40 degrees, with associated central nervous system abnormalities, such as mental status changes, seizures, coma, and organ failure. ICU mortality is 60%. 60%. That is very huge. That's a large mortality. And 30% of those who survive have long-lasting neurologic deficits or motor dysfunction. So this is not only a highly mortal condition, it's also a highly morbid condition. Even if you get that patient outside the ICU, their problem is not done. There are classically two different forms of heat stroke described. The one that is increasing in particular with our heat waves is the classic, which is long exposure to high temperatures. And usually these folks have underlying comorbidities. It's the older person who's outside, and they're on medications that make it difficult for them to dissipate heat. They don't feel the thirst sensation, and their medications are contributing to their problem. The second form is exertional heat stroke, which that's that marathon runner who's trying to get to the finish line and collapses at the end. That's a classic exertional heat stroke. They both have one thing in common, and that's heat. The Society of Critical Medicine had noticed that this heat is becoming a problem in the ICU, and so they asked us to form a multidisciplinary guideline development panel. And you can see that this was multidisciplinary, interdisciplinary group of people who contributed to the formulation of these guidelines. It also spanned practice types, pre-hospital, emergency room, and inpatient settings to get a global picture of the treatment factors that needed to be dealt with for heat stroke. And we used a methodologist from the McMaster's University for the guide group to help us formulate our policies. We started with a PICO. We developed patient intervention comparison and outcomes questions as a group. We pared them down, then did a literature search, did meta-analyses using random effects models, and then graded the recommendations using the grade process, and finally used an evidence decision framework for each PICO. And that way, every single question was harmonized in that same methodology. We distilled this into recommendations. Strong, which is basically a quality measure. This is something you should do for all patients. Weak, there's a lower degree of certainty. You have to assess the patient before you apply the guideline. A good practice statement is a high certainty that the desirable effects outweigh the risks. This is the common sense one, that this is something that's probably in common sense tells you that it's going to work, but there's not a huge body of evidence to support it. And then finally, only in the context of research in which it requires much further study before making any sort of recommendation. So my job was to tell you today about our PICO regarding active versus cooling measures. And our first question, our PICO question, is that in patients with heat stroke, does active cooling versus passive cooling lead to improvements in all the factors that you see on the slide? Survival with good function, rate of temperature reduction, time to target temperature, achievement of a temperature within 30 minutes, organ dysfunction, complications, or hospital length of stay. And you'll notice in our recommendations that many of these are not dealt with. That's because there are zero data. We cannot formulate a recommendation on zero data. So, in other words, we are taking the cooling modality, and the cooling modality is used to adjust for the dysregulated thermoregulation and the heat dispersion that is accompanying with heat stroke. Active cooling, by the thought on the PICO question is that if you lower the body core temperature, there's less organ damage, there's fewer complications, and lower mortality. The types of studies that we were reviewing, you can see there's different types of ways to cool people. There's cold water immersion, 14 to 17 degrees, which had 7 studies. There's using a total body versus just cooling someone's hands and feet. There's cold water immersion of 9 to 12 centigrade using hands or feet as well. And finally, there's a cold shower versus passive cooling. So you can see something already that these studies are not consistent in how they defined passive versus active cooling in patients. And a meta-analysis of all the studies on the passive cooling methods, as you can see, anything to the right, active cooling is good. Anything to the left of the middle line, active cooling is not. And you can see that it overall favors active cooling. However, when looking at the evidence, there's a very serious risk of bias, and there's a risk of inconsistency, which makes the data certainty of low recommendation. So our first recommendation is that we recommend active cooling measures over passive cooling methods in patients with heat stroke. It's a strong recommendation, but a low certainty of evidence because of the consistency of the evidence that was gathered. And that evidence of decision was a number of randomized trials. There's some outcomes that are only evaluated in 2 studies. There's inconsistency in how the studies were performed, what they defined as cooling. So the best we can do is a strong recommendation with a caveat that there needs to be better studies. Our next question was, does the rate of cooling make a difference? And certainly, the meta-analysis of cooling rate demonstrated that ice water immersion by far was the best cooling rate methodology if you have somebody with a heat stroke, followed by colder water immersion and going down the line. The least effective was evaporative cooling with fanning. And doing, again, the meta-analysis, you can see there's some benefit to that cooling rate. Overall, at the bottom diamond on the bottom is off to the right. Cooling rate overall is helpful. However, the evidence, again, is very low in its certainty assessment. And again, it's because they're using different methodologies, not consistently applied in small numbers of patients. So the second recommendation is actually a good practice statement, that clinicians should prioritize cooling methods that have the most rapid rate of cooling, which is ice water immersion or cold water immersion in patients with heat stroke. Again, it's a number of trials, the consistency with the trials, the prolonged time to reach the goal temperature, and the variety in the cooling methods, which makes this data less certain. Our remaining recommendations are good practice statements. And the next is that clinicians should prioritize cooling modalities that achieve a cooling rate of greater than 0.155 centigrade per minute. There are 2 studies that demonstrate some advantage to this. The numbers are insufficient to be able to make this into a recommendation. But in pulling together all these studies, we were able to formulate this table that recommends different modalities for achieving cooling based on the patient's initial temperature. Note that ice water immersion is helpful among the whole region, whereas something like cold saline is only recommended at 40. So this chart can be helpful in determining what type of cooling modality to use in your patients. Our next good practice statement is that clinicians should target the cooling methods that reach the target temperature within 30 minutes from recognition of heat stroke symptoms. That goes along with our previous good practice statement. If you achieve it, that temperature drop, it will happen within the 30 minutes. And on our next good practice statement was clinicians can use this for either classic or exertional heat stroke, and this is because there's a lack of studies to differentiate the 2, so you have nothing to lose by cooling the patient either way. In summary, the recommendations for the cooling portion of the heat stroke treatment is to employ active cooling methods over passive cooling methods in heat stroke, which is a strong recommendation with low certainty. Prioritize cooling methods that achieve the most rapid rate of cooling, which is ice water immersion or cold water immersion. Use similar cooling strategies for either classic or exertional heat stroke. Choose the methods that reach a target temperature within 30 minutes of the heat stroke symptoms, and prioritize cooling modalities that achieve a cooling rate of greater than 0.155 centigrades per minute. Thank you.
We're going to hold questions until the end of the talks, so I welcome you to write them down and save them for later. Our next speaker will be Dr. Jeff Barletta, Professor of Pharmacy Practice and Vice Chair of Pharmacy Practice at Midwestern University in Phoenix, Arizona.
All right, good afternoon, everyone. Thanks for the nice introduction, and it's a pleasure to be here. So I'm going to be talking about the role of medications in the management of patients with heat stroke. And our specific PICO question is shown here. So in patients with heat stroke, do medications that either directly or indirectly affect temperature versus no medications lead to improvements? And you can see the list of outcomes there. And note, these are the same outcomes that were used for the cooling PICO, and similar to the cooling PICO, we had some of the same challenges with the availability of data for all of these outcomes. But the rationale for this PICO was largely centered around the pathophysiology of heat stroke and how medications with their various mechanisms of action could mitigate some of these pathways. And this is a similar slide that was shown before, but I like to show how medications actually fit in here. So under normal circumstances, the heat that's generated through normal metabolism or through the environment is dissipated through thermoregulatory mechanisms to maintain a normal temperature. Now, when these mechanisms become exhausted, you see body temperature increase. And when these temperatures reach extreme levels, well, that's when we start to see a series of deleterious pathways and sequelae that ultimately lead to damage at the cellular level and at the organ system level. So you can see some of the effects at the cellular level, like damage to proteins, membrane lipids, DNA. We have pro-inflammatory cytokines, an increase in the acute phase proteins, activation of the coagulation cascade, and the inhibition of fibrinolysis. If you focus on what happens at the organ system level, you can see that practically every organ system is adversely affected. And most notable here is the devastating neurological injury that occurs. So with that, we sought to evaluate, where do medications fit in and do they have a role? So the drugs that we chose to evaluate were dantrolene, antipyretics, namely acetaminophen, salicylates, and NSAIDs. And then we wanted to also evaluate the role of seizure prophylaxis and antimicrobial prophylaxis, which have more of an indirect effect on temperature. So the first medicine is dantrolene. Dantrolene is used to treat malignant hyperthermia or neuroleptic malignant syndrome. It works by interfering with the release of calcium from the sarcoplasmic reticulum and attenuate the heat that's generated through muscle contractions. Now, when we did our literature search, we found that the data were really limited to animal studies, case reports, but there were 3 randomized controlled trials, and these randomized controlled trials is what was used to formulate the recommendation. Now, there's a couple points that I want to make with these studies. The first is that these were conducted in patients with heat stroke. So unlike the cooling studies are typically conducted in healthy volunteers with extreme hyperthermia, obviously for ethical reasons. But these were actual patients with heat stroke. You can see the sample size in each of these studies. It was relatively small. 2 of the studies used the endpoint of core temperature. 1 evaluated neurologic function. The cooling methods that were used are highlighted here. That is evaporative cooling via atomized water spray with fans. So I like to point out that this is not ice or cold water immersion, which I think is very, very important when we talk about generalizability. And then finally, you can see the dose of dantrolene that was used in these studies. Well, here are our results for the outcome mortality, and as you can see, there was no difference in mortality, relative risk of 1.01, and you can see the confidence interval here is very, very wide. Dantrolene was associated with about a 10-minute difference in time to target temperature. However, this was not statistically significant. One thing I think that's important to note with these studies is that the time to reach target temperature in these studies was on average about 60 minutes. So obviously this is much more prolonged than what we would prefer, and based on the previous recommendation that we should be reaching our target temperatures within 30 minutes. These studies, it was 60, so again, not meeting the standard of practice. This is again largely because they did not use ice or cold water immersion as the cooling method. There really weren't any differences in any of the other outcomes. You can see the data here for length of stay, adverse effects, and then neurologic function. Our certainty assessment profile is shown here. For all of the outcomes evaluated, you can see that the level of certainty was either very low or low, and this is largely due to bias or imprecision. So our recommendation is we recommend against the use of dantrolene in patients with heat stroke. And this is a strong recommendation based on very low certainty of evidence. So you might be wondering, how did we get to a strong recommendation based on very low certainty of evidence? And there were a number of points that the committee discussed during the evidence to decision process, namely the quality of the trials that were evaluated, the fact that they all had wide confidence intervals, none of the differences were statistically significant. We did talk about the high acquisition cost of dantrolene and how this may be prohibitive for some institutions, and particularly those in low resource areas. All of the studies used cooling methods other than cold water immersion or ice water immersion, which led to prolonged time to goal temperature, so some challenges there with generalizability. But ultimately, when we looked at the definition of what's a strong versus a weak recommendation is a conditional recommendation. So that means that there should be conditions where dantrolene would be appropriate. And the committee really couldn't come up with any of those scenarios where we thought dantrolene would be appropriate. Hence, we decided that a strong recommendation would be more appropriate. Next is the antipyretics, acetaminophen, NSAIDs, and salicylates. And these agents work by inhibiting the hypothalamic heat regulating center, namely by inhibiting COX-2 and prostaglandins. Note that there is a mismatch here between the pharmacology of all of these drugs and the pathophysiology of the disease. So admittedly, we really weren't expecting to see much in terms of benefit. And sure enough, when we did our literature search, we found that there were no studies with these agents in patients with heat stroke. So here we issued a good practice statement. The routine use of acetaminophen, NSAIDs, and salicylates for temperature reduction should be avoided. The justification for this statement, again, no studies in heat stroke patients. The committee felt that mechanistically that any benefit would be implausible. We did recognize the potential for ADEs, namely hepatotoxicity, acute kidney injury, bleeding, coagulopathy, noting that these adverse effects are highly prevalent in patients with heat stroke. So the balance between desirable and undesirable effects did not favor the use of these agents, and we felt ultimately all of this was in line with the criteria for a good practice statement. Next are medications for seizure prophylaxis. The rationale for this PICO was centered around the fact that seizures are common in patients with heat stroke, and prophylaxis is considered in some settings where severe neurologic injury is present, like traumatic brain injury. But when we did our literature search, we found that there were no data evaluating medications for seizure prophylaxis in patients with heat stroke. For antimicrobial prophylaxis, the rationale here was based on the increase in intestinal permeability and bacterial translocation, coupled with the breakdown of the blood-brain barrier. So the brain is technically open access for all of these toxins and bacteria. So potentially there could be a role for antimicrobial prophylaxis, but we were unable to find any data evaluating antimicrobial prophylaxis in patients with heat stroke. So here we issued two only in the context of research statements. Prophylactic anti-seizure medications and prophylactic antibiotics should only be used in the context of research. And the discussion points leading to this decision, again, there were no studies in heat stroke patients, but in theory, we thought there could potentially be benefit, but obviously this would warrant further investigation. And we decided that this is more compatible with an only in research statement as opposed to a good practice statement, which would indicate that further research really wouldn't change the decision. Obviously, in this setting, we felt that further studies are warranted. So in conclusion, you can see the statements that were made. We recommend against the use of dantrolene in patients with heat stroke. The routine use of acetaminophen, NSAIDs, and salicylates for temperature reduction should be avoided. Prophylactic antibiotics or prophylactic anti-seizure medication should only be used in the context of research. So hopefully, collectively, you can see the role of medications for the initial management of heat stroke is basically none. Thank you.
Our last speaker for this session will be Dr. Heatherlee Bailey. She is an emergency medicine intensivist at the Durham VA. She is also a past president of the Society of Critical Care Medicine. She'll be speaking to you today about the research gaps on this important issue.
Thank you for the introduction. To put my glasses on so I can see. Getting old is for the birds. So for my disclosures, the main ones that are pertinent for this is the fact that I've been involved with this task force for the last 2 years as the co-chair along with Dr. Barletta. So you've heard the evidence, or honestly, it's actually the lack thereof. And you can understand now the challenges that we have and the statements that we were able to make about the good practice statements and the evidence with low quality of data. Now you understand where that came from. And why is that? Several of them have been mentioned by my colleagues here, but the quality of the current data is lacking. There's a lot of case series and case studies, and it's very challenging to study humans in heat stroke because ethically we cannot give them neurologic change to examine what happens to them. And finding a comparable research model is difficult, as any of you who do lab research understand it, what is similar to a human. So another issue is what is the impact of the individual's susceptibility? We are in the age of personalized medicine with genomics and looking at the individual characteristics and how they attribute to each different system process, such as sepsis, cardiac arrest, and other entities that we take care of. How does the individual respond to the treatment that we give? Not everybody responds the same. And of course, there's the environment. There have been several sessions at this Congress already talking about the effect of heat. So these are the main areas of the knowledge gaps that we need to focus on. Environmental factors, who are the vulnerable populations, individual variability, the pathophysiology and mechanism, and how are they different in each individual? What treatments can be used and optimized, and are they based on your individual metrics? And ultimately, how do we get the best outcomes? Now, when you look at this data, this is information on heat waves, and this is over the last 20 years, and from a distance, this looks pretty good about the amount of data that there is. You can see an exponential rise in the amount of papers that are being produced. However, when you look at the y-axis, the top number is only about 40. So this is a small amount of literature. And then when you take a look at the types of manuscripts that are being produced, they are meta-analysis, systemic reviews, and non-systematic reviews. So not a lot of new data. We're looking at the same information over and over. And then when you look at the focus of the manuscripts, they have been broken down into mostly morbidity and mortality, the blue and the red colors, but the vulnerability and the risk population and adaptation due to heat waves. And Conti then further broke this down, looking at those knowledge gap areas And what were the current recommendations? And the first one is that there's no universal accepted definition of heat wave. So it's hard to then take that information and apply it across all fields. So we, as the task force for the CDR that was published previous to this guideline, came out at Congress last year, we had robust discussions about the different research gaps that we would like answered. And this is certainly not inclusive, totally inclusive or exclusive, but these are certain areas, such as the role of personalized medicine. Is there utility in using AI? When should we stop cooling? We kind of know when we should start cooling right away, but when should we stop cooling? And these are some of the questions that we as a group and as clinicians would like to know. So what I want to focus on right now is, where are we currently at this moment? What are the cutting edge studies and information that is going on around the world? Well, heat stroke study and heat information has been looked at for about 100 years. And it's important to note it started, where many studies do, with the fruit fly. And in 1930, they determined that heat-induced injury occurred in fruit flies and that it led to inherited mutations, so it continued through the genome. So heat changes even the insects. Schlater took a look at, can we use biomarkers? And he looked at the whole process of heat stroke and heat injury, and you saw a little bit of this in the previous presentations, and said, where along the way would having a biomarker be helpful? And we know that there are many different biomarkers, and because of all the different organ system dysfunctions that occur in heat stroke and heat illness, many of these biomarkers will be helpful. Unfortunately, there is nothing that is pathognomonic for heat stroke. We see these abnormalities in many of the different entities that we treat. And then looking at nanoparticles, looking at treatment, we know that nanoparticles are helpful certainly in cancer therapy, but this group, Gual, looked at using nanoparticles to get medication directly into the brain. And what they did was they took curcumin, which is a derivative of turmeric. Turmeric has anti-inflammatory properties, and they linked it to a nanoparticle, and they used a rodent model, and what they found is that after the animal developed the heat stroke and the heat injuries, they gave them this nanoparticle with the curcumin, and then they evaluated the animal, and they found that these animals that survived had less dysfunction, and that when they looked at their pathophysiology, they had less overall inflammation and less cellular damage at the neurologic level. So perhaps this is something that will occur in humans. They also found that the oxidative stress was improved as well, and that there was improvement in removing of the free oxygen radicals. Now, what about alternative models? And no, this isn't Barbie's horse, but it's important to know that all animals can develop heat injury, and this is actually an albino thoroughbred. I've never seen one, I just found this online, and is having a heat, it was a racehorse, and is having a heat illness event. But fortunately, it is mild because the horse is bright-eyed, ears are up, and fortunately is standing. So this is a mild heat illness, but it doesn't really equate to humans. The studies have shown that unfortunately, at least when it comes to heat, we are very similar to the rodents and to baboons. And that is what a lot of the animal studies have shown. Now, this is a rodent model when they were looking to see where is the mechanism of dysfunction, because we know it's in the brain. There's been a lot of studies and information about the hippocampus, but this is looking at the anterior cingulate cortex, and they found that this is a significant injury to this area, and that these animals had injury there, and that's where you have your behavior modification, your emotional response. And they also found that there was significant alteration in oxidative stress and free radical damage. Now, Boucharma, you saw his name in several of those studies that were listed, I think, in Dr. Barletta's presentation, and he found that baboons had very similar effects to human in cardiovascular, neurologic, and thermoregulatory effects in heat stroke, similar to what we as humans do. And he has done studies of multiple different entities, and unfortunately, not one of them showed benefit. In fact, several of them showed worse outcome. So unfortunately, we're still searching. Now, what about a heat stroke model? it's easy to put an animal in a hot environment, but how do you make them work? And this is only slightly facetious, is that there are forced wheel exercises that these animals do go through. They're put in a hot environment and they're made to run on a little treadmill. I'm reporting the data, I didn't do it. Now, this was a mouse study, and in the blue line is the mice that were put in a hot environment. The red line is the mice that were then forced to exercise. And what they found after the fact is that every mouse that was forced to exercise, so emulating exercise heat stroke, had significant bone marrow changes. And those persisted not only at 4 days, but at a month out. These animals were immunosuppressed, and they had altered heat shock response. So that way, if they were re-exposed to heat, they didn't tolerate it as well, and we certainly know that in humans. If you've had an episode of heat illness, you have to be very careful if you go out again. Another important thing is protocols and having a protocol. We as a society know Surviving Sepsis Campaign, the ICU Liberation Protocol, those have helped millions of patients throughout the world. This is no different. This came out just this year, and it shows the importance in this group. They had a significant improvement by making sure that they had stockpiled ice and also containment mitigation systems, because when that ice melts, you have flooding and your staff tends to fall. So you have to have that in the protocol, how to manage the water. But the reality is, much like many things in medicine, we want to prevent the problem in the first place. And so prevention is key. The military has a significant issue and challenges with heat stroke illness, and those of you who are military in here know this is a problem, and there's a lot of data out of Israel who has problems with their military and heat illness, and a lot of that important information comes from them. But what is shown is that through education and preparedness, and this is over the last 5 years, there's been decreased numbers of patients that have had heat stroke and decreased numbers of heat illness. There is still going to be some, but it's due to the fact that there's earlier recognition and identification and knowing how to treat it, so they've showed improved care. Why do we not want to go? Sorry. Another important thing is, how do you mitigate that risk? There are specific recommendations for sports, for military. One of the important things with exertional heat stroke is making sure the patient, if your person is acclimatized, they're getting good hydration, they're at a good fitness level, they've got good nutrition and good sleep. In the US, one of the most common causes of exertional heat stroke in athletes is football. And when they look specifically at who is at risk, 95% of them are linemen. Well, these are the guys that are, 6'5", 330 pounds. They are big guys. They warm up, and it's very hard to cool them down. And what the recommendation is, and this is out of the sports medicine literature from last year, that you should train the individual for the position. These guys don't need to be running sprints. They don't need to be running 10 miles. They don't move very far. Their goal is just to keep the opposing line from coming at them. So train them for the position. And that those punishment exercises, and any of you who have done sports or other things know that drop and give me 20 is probably not the best plan, especially when it's 100 degrees. Now, go Birds. You may remember, if you're a football fan or an Eagles fan, that 25 years ago, there was another blowout game that was also very famous. And this was against Dallas, and they drank that pickle juice, and look at the field temperature. It was 130 degrees on the field, and the Eagles looked fabulous, while the Dallas Cowboys, not so much. And there's been studies to show that the pickle juice did make a difference. This was another rodent study, and they looked at giving them vancomycin-infused water. What was interesting was that the mice liked the vanco-infused water. Now, whether it's because they never get anything that's flavored before, I have no idea what vancomycin tastes like. I don't know, Dr. Barletta may be able to tell us. But it showed that by giving them this ahead of time and then making them exercise, they had increased water intake and overall decreased fecal bacteria, so there was probably less translocation when they had damage to the mucosa of the intestines. Overall, they did not get as warm. Their core temperature was lower. There was less organ damage and less inflammation. So prophylaxis pre-exercise may be something. But I want to caution you, it's not just heat stroke. So for those of you who are sitting here saying, I see maybe 1 or 2 heat stroke patients a year, it's not just heat stroke you have to be worried about. It's the heat. Multiple studies just in the last year about looking at the temperature and neurologic dysfunction. This study in JAMA showed that in the first 10 to 12 hours of a heat wave, so the first day, there is increased risk of acute ischemic stroke. Specifically, when they parsed it down, men were more at risk, especially in the Northeast, because they probably weren't quite as acclimated to the temperature, and those that had dyslipidemia and atrial fibrillation. So education is important. The beginning of that heat wave, everyone thinks, oh, I should go out and exercise before it gets really hot for a week. Probably not the best idea. Study is out of Sweden, and what they looked at was the incidence of hyponatremia, 50,000 episodes. And what they showed when they looked at the data, you can see is obviously the older was at higher risk. And look at the temperature, 20 to 25 degrees centigrade. 25 degrees centigrade is 77 degrees Fahrenheit. Not that warm. I don't even think we've hit 77 while we've been here in Orlando, maybe yesterday, certainly not today. But look at the number of increased rates of hyponatremia. Important to know. And then the last study I wanted to show you just recently came out in December, published online in JAMA as well, looking at heat waves and CNS alteration. Most of the patients were Parkinson's patients, and they found that for every degree over 93 degrees of outside temperature had a 10% increase in admissions and death, all causes. And they feel it was most likely related to autonomic dysfunction and the medications. So it's not just heat stroke you have to worry about. It is the heat as well. So where do we go from here? Well, you've seen what limited literature there is out there. We need literature, and whether it's heat stroke patients, whether you're a clinician, whether you work in a lab, whether you do both, if you have an area of interest, if you have numbers of patients, we need information, we need data so that we know how to treat these patients appropriately, ideally how to prevent it. But if a patient develops heat stroke or heat illness or a heat-related process, such as those neurologic problems that we just saw, what do we do about it? And with that, I thank you for your attention. I'd like to thank our entire task force. Everyone did an excellent job and contributed. I'd like to thank Dr. Barletta for helping guide us through all of this, the challenging process and the data that we had to parse through. And I'd also like to thank the society for allowing us to focus on this important entity. Thank you very much.